Every year, roughly 600,000 spinal surgeries are performed in the United States alone. Nearly half of those patients are over 65. And here is what the data shows that most surgeons will never tell you up front. For many older adults, going under the knife doesn't just fail to help. It actively makes things worse. There are 5 specific surgeries being routinely recommended to seniors today that carry staggering risk-to-benefit ratios that most patients never fully understand before it is too late. I have seen the outcomes. I have read the studies. And I want you to understand what they actually say before you or someone you love agrees to anything. I'm Dr. Sarah Mitchell, and on this channel, we cut through the noise to give seniors the clear, evidence-based medical information you deserve. Every week, I dig into the latest research so you can make truly informed decisions about your health. If that matters to you, please subscribe so you do not miss what is coming next. Now, let's get into these 5 surgeries, starting with one that is performed over 450,000 times every year in this country. Number 1 is elective lumbar spinal fusion. If you have been dealing with chronic back pain, there is a real chance a surgeon has already mentioned this procedure. It sounds logical. Fuse the unstable vertebrae together. Stop the movement. Stop the pain. But here is what a landmark study published in the New England Journal of Medicine found after following patients for 4 years. Outcomes for spinal fusion in patients with degenerative spondylolisthesis were not significantly better than supervised physical therapy and targeted pain management. Not significantly better. And for seniors specifically, the complications can be devastating. Infections at the surgical site, hardware failure requiring a second operation, something called adjacent segment disease, where the vertebrae directly above or below the fusion begin to deteriorate because of increased mechanical stress. Recovery takes months, and during that time, older adults face serious risks of blood clots, pneumonia, and muscle loss that can be very difficult to reverse. Margaret was 71 years old when her orthopedic surgeon recommended lumbar fusion for her chronic lower back pain. She was active, living independently, walking her dog every single morning. She went through with the surgery. 2 weeks after the procedure, she developed a wound infection. She spent 6 weeks in a rehabilitation facility. A full year later, she still had not returned to her pre-surgery activity level, and her pain was roughly the same as before. Her surgeon called it an unfortunate outcome. What nobody told Margaret before the procedure was that she could have started with 12 weeks of targeted physical therapy. The research shows outcomes are often comparable without a single incision. Before I continue, I want to ask you something directly. Have you or someone in your family ever been recommended for spinal surgery? Drop a comment below and tell me what you were told. I read every single comment, and your experience might protect someone else from making a decision they will regret. Number 2 is radical prostatectomy for low-grade prostate cancer. This one is critically important for men over 70. The PROTECT trial, one of the largest randomized studies ever conducted on prostate cancer treatment, tracked over 1,600 men for 15 years following diagnosis. The results were striking. Men with low-risk prostate cancer who chose active surveillance had essentially the same survival rates as men who underwent surgery or radiation. The same. But the men who had surgery? 30% experienced long-term urinary incontinence. 66% reported significant erectile dysfunction. These are not minor inconveniences. These are permanent quality of life changes that affect everything. For a man over 70 with a Gleason score of 6 or lower, this cancer is biologically slow-moving. You are statistically far more likely to die with prostate cancer than from it. That does not mean ignoring the diagnosis. It means monitoring it carefully with regular PSA tests and periodic biopsies, and not rushing toward a surgery that carries serious, often irreversible consequences. Surgery is not always the courageous choice. Sometimes watchful waiting is the more sophisticated, evidence-based decision. Any doctor who dismisses active surveillance without walking you through the PROTECT trial data is not giving you the complete picture. Number 3 is open heart surgery for aortic valve replacement when a minimally invasive alternative already exists. Aortic stenosis, the narrowing of the heart's main valve, becomes increasingly common after 65. For decades, Cracking the chest open was the only real option. Then came TVR, transcatheter aortic valve replacement, where a new valve is delivered through a catheter inserted into an artery in the leg. No chest incision. No heart-lung bypass machine. The PARTNER 3 trial and the Evolut low-risk trial both demonstrated that TVR produced outcomes equivalent to open surgery in intermediate and high-risk patients and in elderly patients with multiple health conditions. TVR clearly outperformed open surgery in 30-day survival and speed of recovery. If your cardiologist recommends open valve replacement without mentioning TVR, ask this question directly. Am I a candidate for the transcatheter approach? For most patients over 70 with aortic stenosis, open surgery in 2024 requires a compelling justification, not a default recommendation. Now let me pause here because what I am about to tell you about surgery number 4 surprises nearly everyone who hears it. Number 4 is elective repair of asymptomatic inguinal hernias in older adults. An inguinal hernia is a bulge in the lower abdomen or groin where tissue pushes through a weak spot in the abdominal wall. If yours was found incidentally on a scan or during a routine exam, and you have no pain, no discomfort, and no limitation in your daily life, the research now strongly supports watchful waiting over immediate surgery. A study published in the Annals of Surgery followed elderly patients with asymptomatic hernias for 5 years and found that the vast majority did not progress to emergency complications and reported similar quality of life to those who had elective repair. Meanwhile, hernia surgery in a 75-year-old with even mild heart disease or diabetes carries real anesthesia risks, a recovery of 4 to 6 weeks, and a meaningful risk of chronic nerve pain at the surgical site. If your hernia is not bothering you, document it, monitor it with your physician, and unless it becomes painful, rapidly enlarging, or trapped, there is no urgency to cut. Number 5 is elective colon resection for recurrent uncomplicated diverticulitis. Diverticulitis, the inflammation of small pouches in the colon wall, affects roughly 1/3 of adults over 60. After a second or third episode, many surgeons recommend removing the affected section of the colon to prevent future attacks. For decades, this was standard practice. But evidence from the DIRECT trial, published in JAMA Internal Medicine, showed that elective colon resection after recurrent uncomplicated episodes did not result in better quality of life compared to conservative management over 5 years of follow-up. For elderly patients with cardiovascular disease or diabetes, colon surgery carries substantial risks including anastomotic leak, infection, and prolonged hospital stays. The critical word here is uncomplicated. If your diverticulitis involved an abscess, a perforation, or a fistula, that is a different conversation entirely, and surgery may be completely appropriate. But for recurrent episodes that are resolved with antibiotics and rest, the evidence no longer supports rushing to the operating room. Here is exactly what I want you to do before agreeing to any elective surgery. Ask your physician 3 specific questions. First, what does the published research show for patients my age with my particular health conditions? Not patients in general. Patients like me. Second, what is the evidence for non-surgical management, and how seriously and how long have we actually tried it? Physical therapy, medication, watchful waiting, lifestyle changes. Have we genuinely exhausted those options first? Third, can I get a second opinion from a specialist at an academic medical center? A surgeon at a community hospital may have very different incentives and patient volumes than a specialist at a university hospital. A second opinion is not an insult to your doctor. It is your right as a patient, and it is the medically responsible thing to do. Keep copies of your imaging results and lab reports together in a folder. Bring a trusted family member to surgical consultations when you can. Someone else listening catches information you might miss when you are anxious or overwhelmed. And do not let anyone rush you. Urgency around elective surgery is almost always a warning sign. Genuine surgical emergencies are unmistakable. If someone is pushing you toward the operating room faster than you are comfortable with, it is entirely appropriate to slow down, ask for time, and get more information. Please consult your own physician before making any changes to your care plan. Everything discussed here is based on published medical research and is intended for educational purposes, not as a substitute for personalized medical advice. If this video made you stop and think before signing a surgical consent form, comment below right now. Type "reviewing my options" if you plan to ask these questions before any future procedure. Type "sharing" if you are sending this to a parent, spouse, or friend who needs to hear it. Or just tell me which surgery on this list surprised you most. Your comments help this channel reach more seniors who are facing these exact decisions. If you are not yet subscribed, please do that now. Every week, I bring you research-backed health information designed specifically for people over 60, because you deserve access to the same evidence your doctor has, explained clearly and honestly. Next week, I am covering 5 prescription medications that geriatric specialists now flag as particularly risky for seniors over 70, including one blood pressure drug that nearly every primary care physician still prescribes. You will not want to miss that video. This is Dr. Sarah Mitchell. Ask hard questions, take your time, and remember that advocating for yourself is not difficult. It is being informed.